Good afternoon, everyone. Today I'm going to discuss regarding the sensation of pain physiology, which is very important sensation. As all of us know, that the patient coming to us, the majority of the time the symptom is pain. So it is very much related to us as doctors, practitioners, and this is what we have to heal. So the doctors are known as healers just because this symptom particularly is very much important. The physiology of this particular sensation we are going to discuss today. What we are going to discuss is first is definition of pain, what are the different receptors, what different types of pain we can see, the receptor types, how we can classify according to them, how the pain sensation is carried through the central nervous system, what are the different pain inhibition which are known as analgesia system that are present in our body, different varieties of pain, and how we can assess the pain. So let us see how it is defined. Now, pain is defined as unpleasant sensory and emotional experience with actual or potential tissue damage. So if you read it completely, this is unpleasant. Of course, it is an unpleasant sensory sensation. All of us somehow has experienced it. So it is unpleasant. But it is always attached with an emotional experience. So this particularly two words are combined for the definition. And it is can be with actual tissue damage or it can be with potential tissue damage. And this particular quality it is given to the pain sensation that you can experience this with potential tissue damage also gives this pain particular a property which is acting as a protective reflex. So we can protect our body from the potential tissue damage. So this is unpleasant sensory and emotional experience with actual or potential tissue damage. The Latins, of course, many of the terms they have derived from the Latin word, and this main word was also derived from piuna, which is a Latin word, and the meaning of the piuna is punishment. And if you consider this particular sensation, it is not a sensation, it is more of a perception. And it is always accompanied with a psychological state. It is always subjective and it is differently experienced by each individual. All of you must be agreeing with this particular fact. Now let us see how this pain sensation is received. What are the receptors? These pain receptors are known as nociceptors and they are specialized pain organs and found almost in every tissue. We have seen that we can judge the potential tissue damage also. So that is why they are almost present in every tissue. What are these nociceptors? There are two types of nociceptors, the free non-matrix. One is A delta myelinated fibers and the other one is C unmyelinated fibers. And they can be activated by stimulus such as mechanical, thermal or chemical, but they will require a high threshold to be given up to a mark of noxious stimulus. Then only the pain sensation will be stimulated, the receptors will be stimulated. Now these screen paintings, they have a particular characteristic. In the examination, this is a favorite question which is asked as a short answer question, as a part of long answer question, and it is a part of Viva question also. So this is very much important. As we have seen, there are two types of fibers. A delta myelinated fibers. They are less in number, they are myelinated, and that is why the diameter is more around 2 to 4, 5 micrometers, and the conduction velocity is of course more. It is carrying at a rate of 12 to 30 meters per second. It is more sensitive to pressure sensation, the stimulus, and it carries the fast component of the pain sensation. Whereas the other phenomenon, they are much more weak fibers. They are unmyelinated, so the diameter is less. The conduction velocity is less, around 0.5 to 2 meters per second, and the stimulus by which they are more sensitive, more sensitive are chemical agents and they carry the slow component of the pain fiber. Where these receptors are located. As we have seen, they are almost everywhere. So superficial skin layers, all of them, they have these two fibers. A delta fibers carry the fast component and C fiber carrying the slow component. Apart from the superficial skin layers, some of the deeper tissues like periosteum, joints, arterial wall, liver, capsule, and pleura, they also have these particular receptors. And remaining other deeper tissues of the body, they will be having less numbers of these pain nerve endings. But when there is a widespread tissue damage, definitely these fast pain nerve endings can have the sensation of pain. So there can be a painful sensation which is created by the deeper tissues apart from those which are mentioned here. Now, how these pain stimuli, they carry the impulse, where we have seen that the stimulus which stimulates the pain receptor, the nociceptors, can be mechanical, thermal, or electrical. If this is the stimulus, there will be fast, sharp, well localized, and sticky type of pain which is sensed. If the stimulus is chemical, the pain sensation which will be experienced will be slow, poorly localized, dull, and throbbing. And the chemicals which are involved in this are potassium ADP, ATP, bradykinin, histamine, serotonin, prostaglandin, substance P, etc. So these all are chemicals and they will be of course stimulating the nociceptors, but the pain sensation will be slow and poorly localized. Now you can understand that we have sometimes the pain which can be very well localized. And sometimes of the pain cannot be localized. So the patient will be coming to you, and if you ask them where exactly the pain is there, they sometimes will be able to tell you that this is the point where it is painful, but sometimes it is difficult for them to localize the pain. Then you have to think that there must be the stimulus which is causing this, and what type of stimulus can cause. This is the answer for that. Coming to the pathway, now we have seen that different type of stimuli have stimulated the nociceptor. Now how these impulses carried upwards to the central nervous system. The main pathway is anterolateral spinothalamic tract, and there are two types of pathways, the neo and the paleo. We are going to see that. So see, this is the tract which is at the level of the spinal cord. So we can see there are two types of fibers, A delta fibers, and they are going through these laminas. They will be second order neurons, and these second order neurons will be crossing through the midline and going upwards. They will be divided into two types. A delta fibers are for the fast sharp pain fibers, and the C fibers are again going towards the lamina. Here the second order neuron will be there, and from there it will be crossing the midline and will carry the sensation as slow chronic type of pain fibers. And this is how in the spinal cord the pain sensation is carried by these fibers. How they are going upwards. After crossing the spinal cord, these pain tracts will be going upwards. They will cross the medulla, the pons, and then they will reach the thalamus. The slow pain fibers, they are going to reach the intralaminar nucleus of the thalamus, and then they will ascend to the sensory cortex, whereas the fast pain fiber will be reaching to the ventrobasal complex and posterior ventral group of thalamus, and then from here it will go to the somatosensory areas. While going upwards towards this thalamus, they will send some nerve fibers to the reticular formation. So this is how the pain sensation is carried up to the level of somatosensory area. So we have the nociceptors, then we have the spinal cord. They will be divided into two types of fibers. It will be reaching to the thalamus, and from the thalamus it will be going to the somatosensory cortex. So here is many a times the tracing of the slow pain pathway and tracing of the fast pain pathway can be asked in the examination. So we can draw this particular diagram. So this is a particular diagram for the fast pain pathway, which is known as neospinothalamic tract. So these are A delta fibers going to the entering the spinal cord, crossing the midline, then going upwards from medulla, pons, midbrain, reaching the thalamus, the ventrobasal complex, and from ventrobasal complex it goes to the sensory cortex. And while going, it gives the fibers to reticular formation, the periaqueductal gray matter, and to the tectum. So this is how the fast pain pathway is carried. And here the difference will be the fibers, C fibers will be for the slow pain fiber, and it is known as spinothalamic tract. The pathway will be same up to the level of thalamus, but it reaches the midline and intralaminar nuclei. So the thalamus nucleus will be different for fast pain fiber and slow pain fiber. And from this midline and intralaminar nuclei, the slow pain will be reaching to the sensory cortex, the cerebral cortex. So this is what is the pain pathway. So we have seen there are some nerve fibers which are given by both the tracts, the fast pain and the slow pain fiber. So what are these types? The first one was it was giving some fibers to the reticular formation, and that is known as spino-reticulothalamic tract. And this is for diffuse pain and is responsible for general arousal. So whenever you are feeling pain, you can't sleep, and that is a complaint which is given by the patient. इतना दुख रहा था कि हमको नींद नहीं आ रही, and we are not able to sleep. So that is because some fibers are given to the reticular formation, which are need for general arousal. So you become alert because it is a protective type of response. Then some fibers are given to the mesencephalic tract, that is to the amygdala via the parabrachial nucleus. And due to that, as we know that amygdala is responsible for the emotions. So whatever emotions which are related to pain sensations, they will be into these particular fibers because the pain sensation gives some bifurcations to the amygdala. So you have an emotional aspect to the pain sensation. So you irritate, the patient is irritable, the patient is crying, the patient is depressed, so these all are emotional aspects due to the amygdala involvement. Then you have some fibers going to tectum. So that is spino-hypothalamic tract, and this is responsible for activation of neuroendocrine and cardiovascular responses of pain. So sometimes you feel so much of pain that your heart rate stops. Sometimes you feel so much of pain that the cardia is there and then you are syncopated. So that is a cardiovascular response given due to the pain. And the tectal fibers, the spino-hypothalamic tract, is responsible for these particular things. And there are changes, of course, in the endocrine if it is a chronic type of pain. And these tracts are responsible for all these accompanying sensations. Now, as the body is having a pathway for transferring the pain sensation up to the level of the central system, the body also has some analgesia system, which is known as pain suppression inside our body itself. There are two levels. One is spinal, which is known as gate control theory. So, at the spinal level itself, the pain sensation will be gated. So, it will be allowed or not allowed, and then you will be having supraspinal. So there will be some neurotransmitters and they will be acting as inhibitory system. So serotonergic opioid inhibitory system, urinergic inhibitory system, and adrenergic inhibitory system. So how these are going to work? In short, we are going to see this. Now this is the concept of the gate control theory. As we have discussed that this is at the level of the spinal cord. Now, this particular gate control theory was first described by P.D. Paul and Lenzet. This question may be asked in the examination. And what is the basic mechanism is that there is always an interaction between the pain fibers and touch fiber input at the spinal cord level in the form of a gating mechanism. So all of us know that many of the sensations they are entering at a similar point inside the spinal cord. So this is the entry point, this is the gate of the sensations. So here the interaction occurs and the interaction can cause the control of the pain sensation. Now how it is this? So this is, see, when the pain fiber is stimulated, the gate will be open. This gate is spinal cord. And if the pain is stimulating, the gate is open, the spinal cord is open, and that sensation is carried to the higher centers and pain is felt. This is what is normally happening. Now see what happens is whenever you are having a pain sensation along with the touch sensation, both are stimulated together. What will happen? The gate will be closed. This particular gate is closed because there will be sensation which is carried more of the touch sensation because the receptors are much more as compared to the pain sensations. So these pain sensations, for this pain sensation, the spinal cord gate will be closed, but for touch sensation, the spinal cord gate is open and you are not feeling any type of pain. So this is how the spinal cord is controlling the pain sensation, and this particular theory is known as gate control theory. And this is the thing. See, so many times if you are feeling pain and what you are doing is you are massaging, you are doing acupressure, you are doing acu some liniments, some ointments. Okay, so what we are doing is just applying the local application, and along with that, if you are giving a massage, that is your pain control theory. That is the spinal control theory behind the pain sensation. So this is how the spinal cord helps in pain inhibition or analgesia system. Now comes the role of supraspinal, but this is not sufficient. That sometimes the pain sensation is so much that even if you are having some massage or something, the that sensation will not go. So there comes the role of supraspinal analgesia, and as we have seen that there are so many types of, this is a figure which is from title. So what we have is these are the structures which will be releasing some chemicals. Say, for example, serotonergic neurons. And these serotonergic neurons will secrete serotonin. These are enkephalin neurons. They will secrete enkephalins. And these all will be activated to secrete some chemicals, and they will be active on these pain receptor neurons. And here itself, there will be inhibition of the pain sensation. And this is again the basis of different types of drugs which are utilized for the treatment of pain sensations. So this is in short the summary of how the modulation of pain is there. See here there is a noxious stimulus, so there will be some chemical substances will be released because we are taking this example. Then we will be having the C8 delta fibers, C fibers. They will be carrying these particular sensations to the spinal cord. From the spinal cord, it goes from the spinothalamic tract to reach the thalamus, and from thalamus it goes to the cortex. And here the pain sensations will be perceived. Now, how it is modulated? It can be modulated by these particular chemicals. So you can apply something here to treat the pain sensation, or there can be these excitatory substances at this particular level. So if you are giving these particular excitatory substances, the pain sensations are carried much more. So these are pain causing substances. Whereas if you want to inhibit the pain sensation, that is supraspinal inhibitory system, then these are the substances which can modulate the pain sensation. So if they are secreted, they will be acting at this particular level and the pain sensation will be relieved. And this is how modulation of pain sensation is there. Now, after knowing that this is how the pain sensation is carried by the pain pathway, this is how it is So there is analgesia system of the body. Now we will consider what different types of pain are felt. Now this is a question which is very commonly asked as a part of SAQ as a brief answer question. And of course the Viva question. It can be somatic pain, which is due to ischemia, injuries, inflammation, muscle spasm. It can be visceral pain, inflammation, spasm, distension, chemicals, and ischemia can produce visceral pain. There may be referred pain, myocardial pain, ureteric pain, catheteristic pain, and there can be radiating pain. That means it is from one place it goes to other place, and it occurs in conditions like appendicitis, or there may be projected pain or phantom pain. So the pain fibers are not there, but still the person is feeling that particular pain. So very commonly, as a part of long answer question, this small question is asked and it can be separately asked as a short answer question, the referred pain. So I'll be discussing much more this. What is that? Pain is arising from the viscera. It is not felt at the site of origin, but is felt at some distant area. So there is a pain, but that particular viscera is not feeling the pain. Some other distant area will be feeling the pain, and that is known as referred pain. The most common example is cardiac pain, which is referred to left arm. Then you have diaphragmatic pain referred to shoulder. This situation is due to error in localization. Why this error occurs? Because there are some theories which are given. One of that is convergence theory. So in that convergence theory, what it is said is that somatic and visceral structures are converging on the same dermatome. So this is also known as dermatomal theory. Impulses through this visceral path are rare. So the central brain is trained to receive the impulses to the somatic pathway. So they have developed from one single dermatome, both the structures. But the brain is trained only to receive impulses to the somatic pathway. And due to that, if the visceral structures are stimulated, the brain interprets it as coming from somatic structure. And this is the convergence theory of referral. Then comes the role of facilitation theory. The somatic and the visceral structures converge on the same dermatome. This is common. Then the stimulation of visceral causes the facilitation of somatic structures. So you know that both of them, if combinedly are facilitated, there will be pain which is felt at the remote area. So this is what is referred pain. Sometimes there are pain which is felt in different types of situations, and one of that is phantom pain. So here see you can see the picture that there is no limb. So there is a phantom pain. So there can't be any stimulus, but the pain is felt. And this is known as phantom limb pain, which is very commonly seen in amputated limb. And this is due to law of projection. So here again, the law of projection is they have stressed out from the receptor to the brain areas that this is the pathway for the pain sensation. And if suddenly this pathway has been cut, even if the receptor is not there to stimulate the pain sensation, the person will be feeling the pain, and that is why it is termed as phantom limb pain. Sometimes the stimuli is present but no pain is felt, and this is very commonly seen in soldiers, in battlefield, sports persons. So you are having severe pain, but the person is not feeling pain at all. So this is known as emotional attachment. There comes the role of the side tracts of the pain sensation. Sometimes the pain due to a stimulus that does not normally provoke pain, and that condition is known as analgesia. So there is no noxious stimulus, even if you are touching that particular surface, the person will be feeling pain. So the touch sensation is not going to provoke pain, but in that particular patient, the pain is due to that touch sensation. Then this condition is known as halodynia. Neuropathic pain. The pain caused by a lesion or disease of the somatosensory nervous system is termed as neuropathic pain. A used concept is termed as pain memory. So memory of pain pathways always overshadows the primary experience of pain. So you might be knowing, all of us, like if we are seeing just the syringe, okay, just the syringe, you can remember that how much painful it was. So that memory of pain is always overshadowing the primary experience of pain. So this you have to think. Memory of pain can be more damaging than the initial experience. The central sensitization increased responsiveness. Peripheral sensitization again increased responsiveness. And clinical interventions are now tried to blunt these responses. So it becomes very difficult to uh, sort out this particular pain memory. So sometimes the patient comes to us and due to that there is a central and peripheral sensitization, due to that there is increased responsiveness. So even if something is shown to the patient, there will be uh, more experience which is more damaging than the initial experience. So you have to think of this particular factor also. Now coming to the pain assessment, how we can do the assessment of pain. What you have to do is history taking should be very much comprehensive. You have to take medical history, physical history, family history, very comprehensive, in detail. Then you have to go for physical examination, questioning about the characteristics of pain like onset, duration, location, quality, severity, all this should be done. Evaluation of the psychological status you have to. And if you want to remember, these are the pain assessment mnemonics. If you don't want to miss the history taking part, the PQRST. P is precipitating factors, Q is quality, R is region or radiation, S is severity, T is time. So you can remember this PQRST, and if you are asking the questions regarding this, it becomes easy for assessment of pain. You can also remember what's up, where, how it is, aggravating and elevating factor, timing, that is onset, duration and frequency, severity, useful associating data, and patient's perception. So either of these mnemonics you can remember and then you can ask the question to the patient. So it will be easy for you to remember that. There are some scales which are known as rating scales on which you can rate the type, the degree of the pain. And this is pain intensity scale, which can be like no pain, mild pain, moderate pain, and numeric pain from 0 to 10. So you can ask the patient to grade it. That can be visual analog scale. There can be faces scale. So you can ask the person to grade this particular scales, and these are very commonly used in the clinical practice. Then there are some rare conditions where there is congenital absence of pain fibers is there, but it is very dangerous as even though pain is unpleasant, we have seen that it acts as a protective sensation, and if there is no pain fibers, then the protection is lost. But this is very rare, and this is what is seen if that condition is there. So you get damaged parts of your body, and this is how the patient presents to you. So this is, I think, related to the particular part of the physiology. You can remember in short how we are going to treat this particular pain sensation. You can use analgesic drugs. You can remember the supraspinal chemicals. So you can use similar types of drugs, and this is how the painkillers are developed. You can go for acupressure, you can go for acupuncture. There is some TENS mechanism which is known as transcutaneous electrical stimulation, or you can do for cordotomy. You can go for that. And what happens in the cordotomy is that it is the transection of the anterolateral column to interrupt the spinothalamic tract. So here the cutting of the cord is done. It is one of the most popular neurosurgery nowadays, which is very commonly done, and this is done for the painful situations. Since the spinothalamic tracts have crossed, the cordotomy should be done opposite to the side of it. But as some pain fibers travel in the its lateral pathway, after the operation also, we can't these are the treatment options for the pain sensation. Thank you for listening a pain-free lecture. Have a wonderful